Good evening, everybody. Welcome to DSA RVA's Medicare for All event featuring the heavy metal healthcare advocate, Tim Faust. To those of you that don't know me, I'm Austin, the co-chair of the local DSA, and I'm very glad to have you all here with us today. But before we get started, I would also just like a quick round of applause for Gallery5 for hosting us today. As well as a quick round of applause to our co-chair Laura in the back over there, who did a really good job putting this all together, so just real quick. So, you know, today's a very important event for us because it tackles a very important issue. Medicare for All is an issue that DSA, the Democratic Socialists of America, as a national organization, has decided to take on as one of its priorities, and it's for the simple reason that nobody should have to die for being poor. We have plenty of good materials on our table over back there, and I encourage you all to grab a brochure as well as some literature on the subject. Tonight, we have a couple great speakers, including Jenn Galienne, who is Trans Health Services Coordinator at Health Brigade, which is one of my personal favorite local organizations because of the amazing work they do for trans individuals. We'll hear all about it as soon as Jen comes up here. Later on tonight, we'll be screening the documentary Fix It, Healthcare at the Tipping Point. But without further ado, I would love a warm round of applause for a man who has been traveling around the South for the past few weeks, spreading the good word of Medicare for All, the heavy metal healthcare advocate, Tim Faust.
Thank you, Richmond DSA, for inviting me. Thank you, Laura, for setting it up. Thank you, this microphone, for being just where I need it. And thank you all y'all for coming up. Like Alex said, my name is Tim Faust, Timothy Faust. I've been driving across the U.S. for the past 3 weeks. This is my last stop on a 3-week tour. Boy, are my arms tired. About 4,000 miles in my ancient Honda CRV, and then tonight I drive back to Brooklyn, where I live with my new dog, so I'm looking forward to petting him tonight. It's been a lot of fun, so I'm going to talk to you all. You guys are getting Tim After Dark because I'm just basically spent, so we're going to hear a lot of fun things about single payer and health justice. I'm really amped to hear Jen talk. Trans rights are healthcare, health justice, and being just in trans issues is first and is centered in healthcare advocacy. So I'm looking forward to hearing that talk. And then we're doing Q&A, I think, right? That's still in plan? Cool. Happy to A any Qs y'all have, but I hope that y'all will help A some of my Qs. Kind of the point of going around the U.S. and talking about healthcare is learning more about what healthcare and health inequity looks like from place to place, right? What healthcare looks like in Brooklyn or Milwaukee or Pittsburgh or Little Rock is different from each other, and that's different from how healthcare looks in Richmond. So I really want to understand, and I need to understand, if I want to be a good advocate, which I do, kind of what it is comprehensively that we're fighting from coast to coast and plains to Gulf. So I hope y'all will help me understand what health justice and health equity and inequity looks like here. Also, by way of disclosure, the job I went part-time on to travel around and talk about single payer is in the insurance industry. I do work as a data scientist for an insurer. So please consider this my atonement for participating in capitalism. There was no, working in insurance is maybe absolutely convinced that we need to nationalize the insurance sector entirely. If, however, what I do for work bothers you for some reason, that's fine, it bothers me too. We can talk about it afterward, but hopefully it's pretty clear that what I'm saying up here is in no way indicative of my employer or my employment status. So with all that out of the way, I want to talk about healthcare in America. I want to talk about what we have, what we want instead, what must come next, and what we all can do to fight for it, right? I want to talk about the overwhelming and numbing brutality of for-profit healthcare. I want to talk about the relatively benign structural changes that we demand instead, and then I want to talk about something bigger, a broader vision of a better world, the moral compulsion of health justice. That arc sound good? Y'all still with me?
Yeah.
Fantastic. So can I swear here? This seems like a bar. Yes. I think, fantastic. I've done these things in churches. A little bit different there. I want to start off by confirming something you probably feel in your bones, which is that you're being fucked. And the method by which you're being fucked might vary from person to person, or the severity, or the complexity, or the artfulness of the cover-up varies across body to body and person to person. The US spends more money than any other country in the world on healthcare, almost twice as much as the second amount per capita, and yet 75% of our spending is on chronic conditions that are entirely preventable. But yet we refuse to prevent them, because it's not profitable for a hospital's CEO or an insurance company or an equipment manufacturer to prevent them in the first place. So we have created a world in which you are made sick and then punished for being sick so that somebody else can make a huge profit. Let's talk about that. By and large, the costs of receiving health care are much, much more than any individual person can afford by themselves, but not a lot of folks need health care in a given year. In a given year in the US, 50% of all medical costs come from 5% of the population. 80% of all medical costs come from 20% of the population. Now those populations are fungible, right? It moves around from person to person. Maybe some years you get hit by a car, or you have a heart attack, or you have a cancer scare, and other years you don't. So costs move around, but when they hit you hard. So if everybody had to pay for all of their own costs out of pocket, eventually millions of people would go into crushing debt or poverty or medical bankruptcy because of illness. That's not a guess, that's history, because out-of-pocket expenses used to be the only way we funded healthcare costs, and it wasn't until the 1880s when a bunch of socialists and a bunch of unionists and a bunch of doctors insisted that letting people go into poverty because of illness wasn't acceptable that we shifted to a new payer model, the idea of insurance. Now, insurers are organizations, or in the US, companies that receive revenue by charging you monthly premiums. When someone gets sick, insurers spend the money they collect from everybody to pay off a portion of those healthcare costs, plus keep a profit for themselves. So the more revenue an insurer receives from a wide base of customers, or realistically, the more subsidy it receives from public money, the wider those costs are spread. And because most people don't get very sick, the lower the insurer's per person costs. This is a concept called a risk pool. But if an insurer who covers, let's say, between 1,000 or 10,000 people, maybe up to 100,000 people, has too many sick people, like, for example, if they get just one more person with hemophilia, whose care could cost up to $1 million a year, those costs are spread over a pretty thin pool, and per person costs really increase. And so to compensate, insurers increase premiums, but then people that can't afford those premiums drop out, except, of course, people that can't afford not to afford those premiums because they really need the insurance. They stay on board, so per person costs go up even further, so do premiums, and this whole thing builds a really stupid, vicious cycle. Thus, an insurer wants as large and as healthy a risk pool as possible, or it wants to find ways to kick out sick people or coerce them into leaving. Maybe it drops coverage for the kinds of medicines people that need healthcare need, or removes access to hospitals near where sick people live. So the task of an insurance company is really to make people who need healthcare as much as possible somebody else's problem. That's what we mean when we say that we live in a world in which healthcare is a commodity. Right? Because future's on your heart, and future's on your lungs, and your chance of getting diabetes, and whether or not your Mima's glaucoma gets better or worse before she goes into Medicare are fiddled with and speculated about and bought and sold for profit by private companies. Now, over time, we've delegated the responsibility of providing insurance to employers. That means that every single year, unions have to negotiate for worse and more expensive insurance instead of being free to organize around better wages, better contracts, and workplace safety. And on top of that, this results in a status quo of total employer domination, in which your access to things like contraception, or hormone therapy, or blood transfusions, or what doctors you can go to are determined by the whims of your employer. But if you aren't lucky enough to have an employer, right? If you lack the so-called better skills to get the finite number of better jobs, you're just left behind. The people who profit from the commodification of our bodies have decided it's acceptable to shackle the well-being of children to whether or not their parents were lucky enough to have gone back in time 40 years, learned to code, and found a benevolent employer. So welcome to the hell world of America 2018. Now, of course, it gets worse. It's way too early in the talk for things not to get worse. Because the costs of healthcare keep increasing. They've been increasing since we first began recording them back in the 1880s, faster than inflation. Now, a part of these cost increases are for good reasons, right? More people are living longer with chronic conditions, and we spend more money to take care of people longer. Fantastic. Things like diabetes, cancer, heart attacks, trauma aren't the immediate death sentences they were even 2 or 3 generations ago. Great, more people live longer, more money, fantastic. But most of these cost increases are because hospital CEOs, equipment manufacturers, pharmaceutical companies, close personal friend Martin Shkreli, keep finding ways to charge more and more money for the same services or rack up fees for unnecessary services, and no private insurer can really stop them. Here's how that shakes out. In the US, the average inpatient procedure costs 40% more than the exact same procedure when performed in France. Or take MRIs. You all know MRIs? MRIs are just big fancy computers that print money. And in the US, an MRI procedure costs 5 times what the exact same machine performing the exact same procedure costs in Australia. The costs are high because the prices are high. Or most egregiously, let's consider the relationship between primary care and hospitals. Primary care are the things like checkups, basic medications, the kind of face-to-face familiar health care you get from your family doctor or your GP. It's high volume, it's low margin, and by and large, it's not super profitable. But now conversely, a hospital gets paid an average of $2,000 a night for an inpatient stay. So if you're a hospital CEO, this makes a hell of a lot more sense to push folks into inpatient admission instead of letting them waste their time getting cheap primary care outside the hospital, so long as someone's paying for it. Now, of course, that means diseases will be caught late, if at all, and people will just get sicker and sicker and thus more and more expensive to treat. But so long as they've got insurance, the hospital's still getting paid, and the hospital specialists are still getting paid. And so what's the result? 58 million Americans live without access to primary care. 28 million of them live in the South. So as you can see, there's kind of 2 fundamental truths to American healthcare. One, if you're a payer, like an insurance company, it's just not profitable to insure sick people or people that have high healthcare costs. 2, if you're a provider, like a hospital, it is extremely profitable to charge sick people as much as possible, as late as possible, so long as an insurer is footing the bill. And so upon these jagged rocks, we've built this big, stupid church of American healthcare, in which the body is valued solely as a source of profit. Now, this whole situation scares the bejesus out of everybody involved, particularly the payers. Payers are interested in finding ways to mitigate rising costs because they don't want to pay them. Often that means just refusing to pay for claims altogether. That's probably happened to you or somebody that you love. Before the Affordable Care Act, it meant that payers would often just refuse to cover people who were likely to get sick. You know the phrase pre-existing conditions. But this still isn't enough to bring costs down. So we all got together, everybody in America, back in the 1970s, and invented the idea of consumer-driven healthcare. It's the idea that you should make consumers, which is just a libertarian way of saying people, pay more for the costs of their own healthcare, right? Because that'll turn them into smart shoppers somehow. And through the power of the free market or whatever, they'll shop around and not get unnecessary or too expensive care. They'll find the cheapest ED in town if they get hit by a car and Yelp their surgeons. And all of this together will somehow drive prices down. You know that's silly. We've just internalized the language of the oppressor. And all this builds to an atomized, unambitious, and honestly pretty lonely worldview of what healthcare is and what healthcare can and should be. It treats being sick or being poor or being able to get pregnant as a character flaw. And that means if you get hit by a car or you give birth to a premature baby or you get hookworm, you're on the hook for your own costs because it's your responsibility. Because we are told healthcare is a matter of personal accountability. You know what the worst part is? It doesn't even fucking work. No, people who are forced to pay for healthcare costs they can't afford just don't seek healthcare. I don't mean catastrophic care or emergency care. People still seek that. I know people don't seek primary care. They don't seek preventive care. They are coerced into ignoring that rash or trying not to look at that tumor or thinking away that chest pain. Because we demand people bear the burden of healthcare costs they cannot afford, they turn their bodies into ticking time bombs until they have a heart attack at their jobs and leave their families behind. That sucks. So what do? Right? How do you square the rampant increase of healthcare costs with the fact that it's just not profitable to insure sick people? Well, if you're the Democrats, you could collaborate with the Heritage Foundation to offer us the Affordable Care Act, which is, at its core, the massive subsidization of private industry with public money. The ACA is a big bargain, a plaintive wail. Please, 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 it asks, how many billions of dollars do we gotta give you so you stop kicking sick people off their insurance plans? Now, the ACA, of course, had some successes, unquestionably. First and foremost among them, the expansion of Medicaid. In places where Medicaid was expanded, we saw a 6.1% reduction in the mortality rate. That's 11.1% among communities of color. Now, the reasons for that, we understand. These are folks that have been systematically, if not violently, denied access to health care in the first place. So even the relatively meager contribution of Medicaid does a hell of a lot to help a bunch of people lead healthier and longer lives. That's fantastic. But at the end of the day, costs keep increasing. Quality of care stagnates for the most vulnerable among us, and as of 2 weeks ago, 31 million people are still uninsured. Thus, the ACA has failed in its pursuit of health justice. And so here's the table stakes. Among so-called developed countries, America is the most dangerous place to be sick. Among peer countries, America is the most dangerous place to be black, the most dangerous place to be a child, the most dangerous place to be pregnant, with the highest maternal mortality rate, 60% entirely preventable, of anywhere in the developed world, the most dangerous place to be a woman, the most dangerous place to be gay, the most dangerous place to be old, and the most dangerous place to be disabled. Last year, life expectancy at birth fell for the first time in over 30 years by 1/10 of a year. Across 4 million people born last year, that's a theft of 400,000 years. But a funny thing happens when you look at the data more closely, right? Of course, because when you look at the statistics more closely, you realize all this danger only exists if you're poor. Because rich people are just exempted from all these problems. Men born in the wealthiest fifth of Americans get to live 15 years longer than men born in the poorest fifth. Among women, that gap is 10 years. So this is war. This is the terrible secret of American healthcare. They are killing us and robbing our corpses to foot the bill. I'll talk more on that in a second. And so this big, stupid, multi-payer, profit-driven Rube Goldberg machine of American healthcare is failing us today, and left unchecked will collapse tomorrow. So instead, we demand something different. We demand a federal, universal, single payer. Now, single payer is a pretty simple concept. Instead of having a bunch of private insurers with a bunch of fragmented customer bases, each seeking to avoid taking care of unprofitable people, we have one publicly owned, publicly funded insurer with a legislated mandate to cover in full all care for all people. That phrase, all care for all people, is important. We don't want Medicare as it exists today, but an improved Medicare for all. You merge parts A, B, and D, throw out part C, and offer comprehensive coverage, including medical, dental, vision, and long-term care for people with disabilities for all people in America. That is free at the point of service with no cost sharing. Here's how it looks in practice. Right now, you want to go to the doctor, or you call a clinic to schedule an appointment, and the first thing you're asked, even often before what your name is who your insurer is. That's because providers, I think reasonably, are afraid of providing services, especially those that are expensive to provide, without guarantee of getting paid, or guarantee of getting reimbursed. So before we can even be considered for care, we must answer the question, on whose dime? This forces doctors to spend half their day filling out forms to justify their work to payers, and it forces nurses to spend a quarter of their time adjudicating claims and seeking authorization from insurers. Under Medicare for All, the question of who's paying for it is answered. Well, it's Medicare. We preserve and protect and enrich the provider-patient relationship by eliminating the question of, well, how can the patient afford this? Everybody benefits when accessing care is affordable or free and easy. Delivering care, being a doctor, being a nurse, being a home health aide, that's complicated, right? Bodies are just big, terrifying bags of goo that we barely understand, and making them feel better is a complicated process, but paying for it isn't. Paying for it's pretty simple. And in fact, we're already paying for it. We're just forced to spend all that money really, really stupidly. Right now, American public money pays for 2/3 of all healthcare costs in the US. Half of that 2/3 is actual Medicare, Medicaid, and VA spending. Other half of that 2/3 is just government subsidies to private companies. Tax breaks for employers, subsidies to insurers, subsidies to hospitals, etc. The remaining third is out-of-pocket costs. an additional tax you pay to private companies in the form of premiums, deductibles, and co-pays. And so the goal is to reallocate all this spending to take care of everybody long term. At the very, very least, a single payer program keeps our current national healthcare spending flat while reducing strain on ordinary folks' pocketbooks. I think Sanders' bill, S1804, predicts that the average family of four making $40K a year sees their out-of-pocket costs go from $5,700 a year to $470. But even before that happens, we free up all the money associated with administrative costs and profit-seeking within the private insurance market. This optimization, or in their terms, innovation, opens up, in a conservative estimate, an additional $370 billion a year, which is a pretty big fucking chunk of change. So what do we do with it? We reinvest it. It needs to take care of everybody's standard of living. We build or reopen primary care clinics in rural areas. We fund community health centers in poor neighborhoods. And we return the money to the labor that does the work. Take, for example, y'all know home health aides?
Yeah.
Or like a sick family member or a sick, somebody you love or a sick friend. A person can receive care in a hospital, right? But again, that costs about $2,000 a night. For a lot of folks, they don't need hospital-level care. They just need medication management or physical therapy or a catheter change, and they can receive that care in their home. That's fantastic because, well, home is where they live, great. Home is where the dog lives, fantastic. Home is where the internet lives, fair to three, doing great. It's also a hell of a lot cheaper because home health visits are billed at an average of $153 per visit. Great, so everybody wins, right? Well, everybody, of course, except for home health aides themselves, because these 1.2 million people for this essential work are paid an average nationwide of $11 an hour. I know it's much lower in Virginia. So we can allocate this money to do what the private market refuses to do, which is pay fair, livable, sustainable wages for essential care that helps everyone. Right now, your private insurer only bears the costs of you receiving care while they're insuring you, because you're going to change insurers in the next couple of years, and eventually, God permitting, go on Medicare. They don't feel any pressure to provide you with care that keeps you healthy in the distant or even near-term future. Instead, we all do, right? Because we all suffer when our friends and family get sick, and our public money is allocated to care for folks in times of crisis. This isn't really a complex idea, even though it seems like it on TV sometimes, but I know all of you know this already, right? For example, you all know that if you're at home in the winter and your window breaks, the cold gets in. And if the cold gets in, you're gonna get sick. And if you get sick, or if your kid gets sick, you gotta go to the doctor. And if the community clinic was shut down or it's really far away, that means you gotta drive, and if you don't have a car, it means you gotta take the bus. And if you gotta take the bus, you have to spend all day dealing with the bus system. And if you just spend all day dealing with the bus system, you can't go to work. And if you can't go to work, you can't afford to fix the window that caused the problem in the first place. And so the answer isn't to fork over a pile of cash every time you go to the hospital. The answer begins with giving people enough money to fix the goddamn windows in the first place. But there are no private actors in the American healthcare model who will ever consider bearing responsibility for fixing these problems on their own. The insurance industry is entirely incapable of addressing the foundational problems of healthcare, of fixing broken windows, of opening and closing clinics, of repairing ruptured septic tanks, of providing free and healthy food to people in the exact same way a billionaire is incapable of lessening income inequality, or a cop is incapable of shrinking the prison industrial complex. They cannot fix the injustice because they have been constructed by that injustice, and that then thus cannot conceive of these problems as problems in the first place. But we can, and we do. And so it makes perfect sense that the same actor who suffers when people don't get care, which is all of us, united, represented by our federal government, should be the actor that pays for that care in the first place. Because once the federal actor bears the costs of providing care and the risks and costs of not providing care, it can finally be used as a tool for realizing health justice. If your people are getting sick and dying because they don't have a place to live, or the places they are forced to live are unsafe, they're full of pollution, they're full of mold, they're flammable. I'm thinking of the ghost ship towers Grenfell Towers in the UK, or ghost ship back home in Oakland, then housing is healthcare. And you must build free or affordable housing to bring healthcare costs down. If people are getting sick and dying because they don't have access to healthy food to eat, and so they're getting diabetes or comorbidities like cardiac failure, then food
is healthcare. And you must provide people with affordable or free food options and the time, space, materials, and community with which to prepare them to bring healthcare costs down. If your population is getting sick and dying because they don't have access to needle exchange programs, therapy, or counseling, then rehabilitation is healthcare. And you must build full-cycle addiction treatment programs, not our current end-of-life palliative care horseshit, but the full social structures required to help people handle addiction or perhaps not fall prey to it in the first place. That's how you bring healthcare costs down. Because single payer is not the goal. Single payer is the tool. Health justice is the goal. And when we fight for health justice, we all fight side by side, because economic justice is health justice. Environmental justice is health justice. Educational justice is health justice. Reproductive justice is health justice. And justice for black lives, justice for brown lives, justice for trans lives, justice for the lives of immigrants, and the well-being of all people, regardless of age, gender, race, or creed, that's health justice. We have inherited a world in which your permission to receive healthcare, capital's allowance you can be safe in your own fucking body, is dependent upon how much an insurer can extract a profit from you. And thus we have permitted in our country utter desolation. Without our consent, we have been forced to participate in the condemnation, criminalization, and abandonment of people in need. People with disabilities have to spend tens of hours a week pleading with insurance companies for a chance to maybe go on a waiting list to receive the bare minimum of care required to keep them alive, if they're lucky. The unlucky ones got to spend their time pleading with Medicaid or Social Security to maybe consider compensating their partners, friends, or parents a whopping $1,000 a month for taking care of them full time. Elsewhere, we've got the opioid epidemic, which was, of course, originally designed as a patent extension ploy with a massive advertising budget. It now kills 180 people a day. And those it doesn't kill are written off as criminals, because only criminals use drugs, so who fucking cares? Put them in jail, they're untouchable. Leave them to rot while their children call their names. In life, it is poor and uninsured people who are used to test the drugs that are then turned around and sold to the wealthy and insured. And that servitude continues in death, because it is the bodies and organs of the uninsured that are ripped and sold as transplants to the wealthy. There is no end to the body horror of capitalism, and there is no line too far for the commodification of the body. America has cheered the privatized slashing and burning of social structures, and then has the audacity to punish people for struggling. When people are in need, we waste time, effort, and money means testing, separating the worthy from the unworthy among those who need help, and then stigmatizing them instead of guaranteeing the basic decency of health equity. This is cyclical. This has happened forever, and it will continue to happen so long as we tolerate, even in whispers, the idea that anybody's body is a commodity. And for systematically marginalized people, sick people, homeless people, people struggling with addiction, people with disabilities, poor people, pregnant people, trans people, women, and people of color, well, when there's no way for the medical industrial complex to find value in their bodies, then there's always the private prison system just ready to receive them for profit. And so single payer is not the revolution. It is our first counterattack in a war that is already waged against us, by which subsequent counterattacks are made possible. It's only right. Single payer is not only the only reasonable method of controlling healthcare costs while guaranteeing universal coverage, it is the tool by which we force ourselves and force the state to reckon with the racist, sexist, and classist provision of healthcare in the country, and to begin to strive toward relief and articulation of health justice. And so, my friends, single payer is moral. Single payer is necessary. And single payer is achievable. Solidarity now, solidarity forever. Water break. So that's the pain and glory of healthcare in America. It gets a hell of a lot worse. There's a bright road ahead, but I want to talk about what we all got to do, right? Because it's kind of fun to yell, but what do? Well, here's what we got to do. We must build, we simply must build the popular movement which begins by demanding single payer from our government and continues to demand health justice in our nation. And when people tell us that we're bringing about creeping socialism, that we're rejecting the American capitalist way of life, we say, no fucking shit, asshole. And we keep on fighting. What's it done for us? We stand, and we're not alone, right? We stand on the shoulders of the labor movement, of the backs of the Poor People's Campaign, which is back and better than ever, of hundreds of thousands of nurses, of tens of thousands of doctors, of thousands of ADAPT protesters that won Graham Cassidy out of the hands of the GOP, who have demanded a clear and focused vision of the future, that the transaction of insurance is not healthcare, and that healthcare is something a just nation affords all its people. How do we do it? Well, we do it shoulder to shoulder, right? The idea of health justice affords us the understanding that we are fighting for a continuous spectrum of demands. And unlike liberal incrementalism, successes at any point along the spectrum, which offer material benefits to people now, make success downstream more inevitable. And so the ways I've seen DSA chapters across the US take on this fight are many, and they're all pretty cool. In Austin, they're fighting for guaranteed paid sick leave at the city level. That goes to a vote in February. If it wins there, it'll spread to El Paso, San Antonio, and Dallas, which is incredible for building a street that can fight for Medicaid expansion in the state. In Maine, they went to the ballot box and fought for and won Medicaid expansion in the last election by using a coalition of minimum wage volunteers, people volunteering for higher minimum wage, and putting on Medicaid expansion. They won that there. In Burlington, DSA is fighting for universal primary care, funded at the state level. It's now in the state house. In Louisville, Kentucky, they realize they have a massive segregated safe housing problem, right? And so they're fighting the city to use tax money from a soccer stadium nobody wants to fund more affordable housing in parts of the city. Elsewhere, people are lobbying for transit networks or offering their own cars and vans to offer transit to people in rural areas that can't get to the doctor's office. Elsewhere, people are uniting with federally qualified healthcare centers and offering organization or just physical labor to get clinics the stuff that they need. So I ask you, please, here in Richmond, to pick the battle that you want to fight for and then go out and win it. I said this before, healthcare is a national fight, but health needs and health justice and health injustice are local. What healthcare looks like in Burlington or Milwaukee or Little Rock or Birmingham or Huntsville or wherever is much different than what healthcare looks like in Richmond. And what healthcare looks like in Richmond is different than what health looks like in the rest of the state, right? The rural and urban areas of states are entirely worlds apart, even if they're just an hour by a drive. In the South, a quarter of the population has been denied access to basic primary care. Half of all people in rural areas don't have healthy food to eat. An eighth of people have diabetes. Now, I caution you, as I caution myself, that it's presumptuous for any of us to believe we can kind of guess the health needs of people around us. The stakes of the single-payer fight are much, much different if you're someone who spends dozens of hours a week trying to get basic care for your needs, or if you've been denied access to care altogether. Thus, it is our obligation as good neighbors and good socialists to extend the basic decency of showing up, of going to people around us, listening, asking questions, finding common ground, defining a cause, and then putting our shoulders to the wheel. If we fight with our neighbors today, they will fight with us tomorrow. We build solidarity now so that tomorrow we win power. And this is a fight we will win. It's also a fight we must. Luckily, the tide of history is in our favor. Medicare for All now polls at 64% in favor nationwide. It broke 50% among self-identified conservatives, I think, at the end of last year. So this is not a radical proposition among the people that it affects. Even noted progressive luminaries like Max Baucus, that fucking snake, have acknowledged that single payer seems inevitable in his lifetime. But I don't want the single payer program we let Max Baucus write. I want the single payer program forged in the concept of health justice, of a broader socialism that we demand. And we will win it, because single payer is inevitable once we make it inevitable. Health justice is inevitable once we make it inevitable. And I am so, so proud to stand shoulder to shoulder with y'all. Now that's it for real. Solidarity now, solidarity forever, solidarity, y'all.
Yeah, that was really awesome. So now, if you could also give me a warm welcome to Jenn Galienne from Health Brigade, who's going to talk a little bit about what she does with them.
I don't usually use a mic. Can everyone hear me? Or would you prefer the
If you
mic?
can speak up a little
Okay,
bit.
sorry.
No, it's fine.
Yeah, that was amazing. I feel like everything he said, wow. So I'm Jen. My official title is Transgender Health Service Coordinator at Health Brigade. We were known for quite some time in our community as Fan Free Clinic, but we recently changed our name. We're the same organization that we've always been. What we do is provide mostly preventative care and primary care to folks that are uninsured and low income in the Richmond area. We have a demographic area that expands beyond Richmond. You can find that information on our website. But we try to do a lot what Tim was speaking about earlier, and that we try to address primary care before folks have to go to the hospital and things like that. So that looks like trans health care, which is what I do, but that also looks like mental health counseling, psychiatry, primary care, OBGYN care, access to food. We do HIV STI testing for free. We put people on PrEP if they're interested in that. We serve folks that are incarcerated that are HIV positive. We do HIV positive care and case management. So we have a broad range of services that we try to do. We believe in holistic care, so not just what's happening to your body, but also what are those other parts of your health that are necessary to keep someone like healthy and alive, right? So that's what we do. I brought some information on the table that has all of our services that talks about more than what I just said and how to get in touch with us. And then, of course, we're not the only ones that are doing this work in Richmond and the area. So I also brought some resources on the table that I'd like you all to take if you're interested, that also talk about other ways in Richmond that you can get care that is either free or for more affordable. I wanted to talk a little bit about this because I was really excited to see things that you can do when you leave here. So the second part, which is vote yes on HB 1466, this is something that myself and my organization and also the Virginia League of Planned Parenthood, their Trans Health Service team helped draft this legislation, and it's really important because in my line of work for trans individuals, we see this, I mean, this is in the whole entire country, but especially in Richmond and in the South, the access for trans individuals to get care is so small and minute, and that's why it's so important for us as an organization to provide trans health care. And it's really kind of fucked up what we're doing in that if you want trans health care in this area, you can count the number of providers that are going to give you affirming trans health care on this hand. And if you get insurance, you might get denied for being trans, or you might have to pay a lot more for services for being trans. Or you might have to go through all these different loops to get the care that you need, such as seeing multiple mental health providers, writing all of these different documentations to your insurance companies, just to prove, that you're trans and to prove that you deserve the care that you need. So when we wrote this legislation, we're just hoping that we can further this so that folks can continue to do this kind of thing. But that's why also Health Brigade exists, in that we will serve trans folks that are uninsured, and we know that the majority of trans individuals are not insured, and that's because our employment sucks anyways, and so in order to be trans and get a job, that's even worse. So we know that there's such a a need to serve trans individuals. So I would just urge you all to check out this bill, figure out who your delegates are, kind of contact them and just say that you stand with this bill. That would be really important to us to do so. That's all I had to really share about my organization, but I'm happy to answer questions if people have specific things. I do a lot of social, I'm a social worker by trade, so if people have questions about resources in the Richmond area, about if you yourself or a family member, someone is having struggle getting to care, that's sort of what I do all day long, is link people to care. So I'm happy to answer any questions that anyone has, or talk with you one-on-one about how to figure out how to do that.
Thank you so much, Jen. Just like she said, right now we're fighting really hard in Virginia to expand Medicaid, and calling your legislators to ask them to support House Bill 1466 is really important. So I'll invite Tim back on the stage here just so we can have a brief Q&A session with Tim and Jen before we start the documentary.
So sorry, I called you Jess. I fucked up really bad.
Oh, no, it's okay.
Sorry.
Oh, thank you.
Hell yeah, let's do some Q&A. What's up?
I'm very happy to see a presentation on single-payer healthcare in Richmond, Virginia. And I just want to talk a little bit, and I don't want to sound like I'm disparaging this effort at all. But my concern is you talked about snakes, and Max Baucus, who infamously threw out single-payer advocates out of the whole debate after Obama was first elected. And I'm also thinking about, as much as I support Planned Parenthood's mission, they've worked on the state level to block a lot of single-payer healthcare legislation, Colorado and California. And I'm also thinking about this past year's election, the primaries. And as a Green Party guy, I have to say, I really want single-payer health care, but as much as some Democrats may talk about it, I don't trust them to ever let it happen. And so, while I certainly join efforts to further single-payer health care, I just caution people trying to work within this corporate duopoly we have here.
Yeah, I certainly am not saying please work in the corporate duopoly. I'm saying we got to build a power base that prevents them from fucking us over even further, right? And here's the thing, if you believe in the idea of the shock doctrine, Naomi Klein, which I do, which is that change happens in the wake of a catastrophe, well, the catastrophe's here. It's been here for a lot of people for a very, very long time, but now it's at a point where this thing is entirely unsustainable, the modern healthcare model. And so, you didn't really ask a question, but I'm going to invent a question that you might be asking, which is, what do we do in Richmond, Virginia, which is a red state? Is that kind of a question you might...
Well, actually, we're a blue state.
Great, sorry. I've been in the South for the past 3 weeks. Sorry, I've had a bunch of answers for Arkansas and Alabama.
And that's kind of my point, is that we're trying to support healthcare for all within our General Assembly right now, and that's great. And Northam has already sort of said that he doesn't see it happening, but he'll listen. And I guess my point is how much do you think we should invest in a Democratic Party that I personally don't think is ever going to allow single payer to actually happen?
Nobody.
So much to talk about.
No elected will represent its constituents unless it fears them, right? Democrats will turn tail. Look at Massachusetts. In theory, they've had 80% of electeds in favor of a state single-payer plan. State single-payer is a bad idea, but in general, for the past couple of sessions, they've chose to not go for it at all, right? Because there's no consequences. What we're seeing is, if we want to win, we must organize. If we organize, we must fight to build power. And power comes in the form of either forcing electeds to, either building direct programs ourselves, forcing electeds to fear us, or building new electeds of our own, right? And the ability to organize on this issue is massive, but we have yet to really realize what's happening. I have an example. I know this isn't a red state, but I did speak in rural Arkansas, I think a week ago, right? Which is an area where I thought, oh, I'm gonna go get yelled at for a couple hours and then like drink 1.5 beers and fall asleep. That's my evening. And the opposite happened. In rural Arkansas, you've got Medicaid clinics being shut down. All across Tennessee. I think Tennessee, rural areas have had 10 hospitals shut down in the past 6 years. I saw a GoFundMe for a rural hospital that wanted to raise $100,000 to keep Copper Ridge Hospital open. And they didn't make it because there's no money in rural areas. Everybody is feeling like the crushing weight of our broken healthcare model, and they're ready and willing and begging to be organized. Are we strong enough, smart enough, and dexterous enough to organize them and demand it from our electeds or force them out? And the way you can do that is you build power in ways that you can. I like Texas as a good example, right? Texas is a red state, but they're kind of showing us a way forward. In Austin, they've got Socialist City Councilman Greg Casar, who's cool, he's in the DSA, who is putting out that guaranteed paid sick leave bill in the city, which was going to a vote and probably will win at the end of the month. That's important because paid sick leave is a version of health justice, right? You can't go to the if you can't go to the hospital for yourself or your sick kid because you will lose money at work, then that makes people sicker and also kind of perpetuates a broader and more grotesque inequality. Now in Texas, like many places in the South, maybe it's not the case here, whenever a city passes a good bill, the state goes up and preempts it at the next leg session. But Greg Casar came ready for that. Last year, he put together the Fair Check bill in Austin. Fair Check is a rule that no employer can run a background check on somebody until they extend that person a job offer, which does a hell of a lot to people that are in the system get access to jobs. And so last year they passed that in Austin, and all the big cowboy hat motherfuckers, I'm from Texas, so I can say that, we're like, well, that's not going to last very long. We're going to preempt that at the state level. You commies in Austin, your days are numbered. But when it came time to pass that preemption in the state level, what happened? Well, everybody who benefited from the Fair Check bill, and most importantly, their families, knocked doors all across the entire state and scared the shit out of the folks, the Republican folks, who were going to vote to preempt it. And on the last day of session, the bill to preempt a Fair Check never even made it to the floor. And Casar won. And now he's got folks that are turning out to organize to push a guaranteed paid sick leave through in the city. And when they win that, Texas has a legend meets every 2 years. They'll do it in El Paso, San Antonio, Dallas. All of a sudden, you've got 4 million people that are benefiting from a material benefit that is in the constructive health justice, and that assembly, that they can win Medicaid expansion in the state. So find the thing that makes sense here and build that power base and push it forward up. Scare the shit out of your electeds or kick them out in the first place. And that's like, I don't think anybody in the DSA loves the corporate duopoly, so force a new model. That's the only way we can possibly win power. In Seattle, they're fighting for forcing cops to hire social workers, because right now in the US, the largest mental health provider is the Cook County prison system in Chicago. When somebody's having a mental episode or an issue, the person that shows up when you call 911 is a cop, and cops are bad, and cops have guns, and a cop with a gun is the worst, like the single person you want least to show up when a person's having an episode, like in a public library or whatever. So by forcing the city to hire social workers in the police force who are unarmed and service first responders, you can do a lot to prevent massacre of people by cops with guns. You can fight for and win that at that city level. In Arkansas and in Tennessee, they're going out into rural. I met a canvasser, just a dude named Leland who rules, who's been going out and canvassing rural farmers in West Tennessee for Medicaid expansion. And he's collecting 40 signatures a day, and he's doing this for fun, because people there are feeling the crisis in their bodies. So I kind of, if like your fear that we won't win because there's a corporate duopoly, that's like a self-defeating tautology. That's a snake eating its own ass. If I agree, like they're not going to give it to us, so we must force it from them. And the way you do that is by building power locally, expanding it, and demanding it of people who claim to represent you. You didn't really ask a question, but I hope that answers it. We good? Cool. We're not getting some more questions. People are thinking. Let's go to you in the back.
Just dovetailing on what you just said, I'm a social worker. I've been in the field for 20 years.
Hell yeah.
It gets me really frustrated. We've been fighting this. We've seen this coming. We have been in the midst of the healthcare crisis and everything that's been happening for years and years and years. So it's extremely frustrating when I hear this from folks because people have been fighting.
Yep.
And they've been fighting. We have the lowest pay, we have the most responsibility with the least amount of authority. And I think we need to join. I mean, you all need to join with us because we're there and we've been advocating for how many years now? I mean, good God, you know, about 100.
Yeah.
I mean, really. And so, and we're grassroots, it's community-based, it's about equality. You look at our social work code of ethics, it's everything you're talking about. And so I get really frustrated when I hear people saying, you know, oh, we can't do anything, or there's, you know, we've been fighting this and fighting this and fighting this. So I just say, my message is like, let's all join together and like get this done. I'm so over it. I'm so done with like the lack of empathy and compassion, the fact that people are not, you know, not treated equally, that I'm so angry. And I think we're all there. I mean, so many of us. And so we have to pull that together and use that anger, you know, as the great motivator. So that's really what I'm saying.
The frontline fighters have been disability rights protesters, the nurses union, and social workers, people that most face the consequences day in, day out.
Yeah.
Can I take a second to say how cool social workers are for a second? Like, I have an anecdote that I think is cool. So, I've got a couple of things on my primary codes, I'll get to that later, but I had one of the things that Medicare can do right now is enforce, there's this model where you can enforce penalties on hospitals, try to incentivize them to do things it wants to. It has bad and good parts, but here's the thing. One of the ways Medicare tries to get hospitals to do good things is by charging them penalties if somebody is readmitted to the hospital right after getting surgery, right? So if I go to the ER for cardiac failure and I get treated and I go back to the hospital 2 days later, Medicare will penalize that hospital for fucking up and taking care of me. And so now this is a thing that was rolled out more broadly under the P4P program after the ACA. And so now hospitals are forced to take more seriously what happens to readmission rates. And Arkansas has, I think they're #1 in the country for diabetes rates and for diabetes complications like heart failure. And so now all these hospitals that their bread and butter is heart failure patients, cardiovascular treatment, cardiology, have to take readmission rates really seriously. And so who reduces readmission rates? Is it the cardiologist? Is it the pacemaker? Of course it's not. The only thing that brings down readmission rates is education, persuasion, information, nutrition, training, and compassion. And the people that do that aren't the cardiologists, and they're not the surgeons, they're the nurses, they're the nutritionists, they're the social workers, they're the patient advocates. So there's a couple models of how you kind of bring readmission rates down. One is this focus on a term that Evgeny Morozov calls technological solutions. The idea that problems are identified solely by their solutions. If a problem exists, there must be an app for it, basically, or a technical or technological fix. And if there is no technical or technological fix, the problem is too ambiguous to control. That's why Silicon Valley has never tackled the problem of homelessness, because you can't app your way to affordable housing for people. So if you fixate on better technology, more improved pieces of gear, spending $30K on healthcare data, people that get cardiac failure, you get a readmission rate on average of 23%. I visited a clinic that has instead invested money in hiring a bunch of nurses and hiring a bunch of social workers to talk to people after they get cardiac failure and offer them a program where they come in a couple days a week and they get nutrition training, they have classes, there's exercise classes, there's a lot of like very compassionate labor. There's this term that Sylvia Federici uses. It's a big gender essentialist. She calls it feminized labor. I might call it compassionate labor, which is all that like soft, slow, tedious work of being nice to people. It's not flashy and it's not profitable, but when you focus on that, the hospitals that do see readmission rates go from 25% to 3%. It's insane. That's what a single payer is forced to focus on if it wants to achieve better outcomes, is revaluing the kind of labor we have systematically and culturally denied valuing for the past jillion years, but more rapidly in healthcare over the past 40. There's a model of primary care that a single payer is forced to consider that I think really highlights the work that nurses and social workers do. We all have, if you want access, if you want better health care, you are this way. Everybody has protections, legal protections or entitlements that affect their healthcare outcomes, right? Everybody has legal protections or forms they can fill out or whatever to like take care of things that make them healthier long term, but you only have access to those if you know where the forms are, which means you need to be able to read, which means you need time, or you can hire a lawyer or an accountant to take care of all these problems for you. So basically you have a two-tier model where poor folks have to scrap by, people that can't read English very well, people that are overworked, and rich folks can hire a lawyer to solve all their problems for them. And that of course just exacerbates intergenerational inequity, intergenerational trauma, intergenerational poverty. So there's a model of primary care we're seeing now that I think a single payer is forced to consider if it wants to because of cost, long-term healthcare outcomes. It's the idea of a medical-legal partnership. It's occasionally good things come out of Boston, this is one of them. It's a Medicaid clinic that exists right now in poor parts of Boston, and it's staffed by a bunch of social workers. So here, it's a real place. My girlfriend used to work there, and here's an example of what happens. A person comes in, a Medicaid patient, and says, hey, I've got a really sick kid. My kid has really, really bad asthma. The social worker says, yep, you need clinical care. Please come to this room, and we'll bring in a nurse, and we'll bring in a doctor, and we'll take care of your kid. But the social worker also knows that there's all these kinds of things that affect a person's chances of getting asthma. For example, home environment. So the social worker asks, or asked, well, what's your home like? And the patient says, well, I live in a slum in Southwest Boston, and there's mold in the walls, and there's pollution in the ceiling, and I have a slumlord, and I can't do shit about it because I'm poor, and why would they ever bother responding to me? I'm powerless. Well, there's a lawyer in the exact same clinic, and the social worker goes and brings over the lawyer, and the lawyer gives the patient a letter that sues their landlord and offers to check back in a week to get their housing back in shape, because you have a legal right to not live in unsafe housing. You guys know Matthew Lesko?
Yeah.
He was on TV in the 90s, public access TV.
Oh, yeah.
He's a guy that wore like a big Riddler suit. His entire John was like, there's free money from the government. Call my 900 number and I'll show you how I can. That dude's entire fucking like life was about finding ways to get you the money the government owes you. Under single payer, like the model of primary care must be a social worker or a nurse or a primary care provider who is excited to find all the ways they can provide you care that you need now, because if they don't, the long-term costs are astronomical. And so there's a question of what happens to labor in the insurance industry if we make a single payer. Where do those 200,000 people go? Well, if you work in the insurance industry, there's a pretty good chance your job is to deal with people on the phone or deal with claim forms and find ways to really kind of give somebody as little care as they are legally required to. And that's the exact same skill set required to find somebody all the kinds of care they should be access to have. So you let these people right now who because they want to pay their bills or raise a family work in a role that ultimately forces them to maybe not help their community, you let them use those exact same skills to help people all around them. This isn't like a utopian fantasy. This is like a basic model of care that any sensible country is forced to invest in. And I think it is one of the deep promises of single payer, is finally forcing ourselves to reevaluate who actually fucking fixes healthcare outcomes in the US. It's not apps that penalize you for using the ER wrong. It's nurses and social workers that give you the care that you need. So that wasn't really a question, but like that's what do you think about who really drives healthcare in America? It is primary care providers, it is nurses, it is social workers, it's home health aides. And we have built a model in which they're systematically devalued, and a single payer offers something more. I'm sorry, I don't mean to dominate the conversation, but let's do a couple more questions. Let's do you, and somebody in the back.
All right. Thank you. I have a primary care physician. I have Medicare. And over the last 2 years, I have gone around among 3 top-notch specialists for a problem. So I make an appointment and it's 6 weeks away. Then they scratch their heads and send me to the other guy. And then I can't get an appointment for 6 or 8 weeks. And then, so literally, I didn't even realize it's been almost 2 years. So I've got these 3 guys, and now there's a 3rd neurologist involved. And so I go on my chart and type to my doctor, this is so cool, we've got all these people. Let's get together and talk about it and come up with a treatment plan. Which makes sense to me. He's a primary care physician, he's the gatekeeper, he's making the referrals. He types me back, well, that's the kind of thing they do at the Mayo Clinic. We don't do that here. And I'm like, well, so who's going to pull all this information together and see that a human being gets treatment? How is single payer going to take care of this? How are we going to get the insurance company out of an individual's life?
Cool. So there's 2 things to that. One is your primary care provider can't afford to spend all that time taking care of you because they're not being paid to. We have built a world in which the diagnosis is the payment mechanism, and if you're a primary care, there's the anecdote that a lot of primary care providers, particularly in rural areas or areas with a lot of Medicaid or Medicaid patients, get to spend 15 minutes with a patient. That's because they got to hustle getting those diagnoses, and non-diagnostic time is not productive time because no one's paying them for it, right? And with a lot of folks, sometimes 15 minutes isn't enough time to even get on the table in the first place. So there's kind of a broader problem there, is that we have systematically devalued primary care. Here's an example of how that shakes out, right? Right now, when Medicare kind of gets to set prices, which it does to an extent, it does so under the advisory of the American Medical Association. The AMA is a cartel of specialists, of hand surgeons, that claims to represent all doctors, but really represents like 60% of them. And they have a committee that tells Medicare like what's happening in healthcare and how to price things accordingly. It's called the Rules Update Committee. And that committee has, for example, 14 ophthalmologists, each one representing all of the 14 kinds of ophthalmology, and one primary care provider, representing the 500,000 primary care providers in the US. So it's representative. And this committee sends out a Google form literally to like 17 knee surgeons, for example, and says, hey, what's new in being a knee surgeon? And they get maybe 10 responses back, and they say, yeah, we checked our records, and it turns out there's 2 kinds of knee replacements now. There's one that happens half as often, and it should cost twice as much, twice as hard. Other one happens half as often, should cost half as much, it's half as hard. Now, on the face of it, that recommendation is revenue neutral, right? You got 2 things that cost twice half as much, half the time. Medicare, in theory, will spend the same amount of money. We have this more specific in our payment stuff. People get paid more justly. So they pass that through. After all, the AMA are doctors, they trust them. Congress approves it, and that issue, or that list of that menu of how many things are paid for and at what rate is given to all hospitals. Hospitals take that list and then charge insurance companies between 3 and 7 times that amount, because they can, because they have the strong side in that negotiation, and charge the uninsured 10 and 12 times that amount. But then a funny thing happens, because then for every single knee surgery performed in all those hospitals, their skyscraper billing departments spend a lot of time making sure they bill exclusively at the top tier of knee surgery. So all that money is being spent and is literally being taken out of the hands of primary care providers. Here's how bad it's gotten. We've created a world which only the children of doctors can afford to become doctors themselves. If we all wanted to fuse together and go be a doctor and go work in rural Virginia, we're gonna go broke, because it's low margin, high volume care. If you're getting paid per diagnosis, you can't afford to spend quality time with your patients, and you've got between $176,000 and $300,000 of medical debt. Right now, I think 60% of students in med school come from the top income quintile in the US. That's for a couple of reasons. Of course, people that are from lower incomes are denied access to education all the way through, but fewer than 10% of people in med school come from the bottom income quintile. And so if you want to go back home to where you come from and take care of folks, you just can't afford to do it if you want to do primary care. So you are forced to kind of consider specialty care. That's where all the money is. You've got this massive income inequality within the profession. So this whole thing is bogus. So one of the 2 things single payer must do is, I think, a parallel fight, but one that only a single payer could take on, is making all medical education, whether for nurses, physicians, social workers, and beyond, free, or offer tuition reimbursement programs. Because we're facing down a pretty big primary care gap in the US. Right now, I think the plurality of primary care providers are older folks because they went to med school at a time when it was cheaper. But as they retire, nobody can fill their shoes. We've got the J1 visa for folks from countries where it's cheaper to become a doctor, but that's not a very big pool of people, and also that affects people's health in other countries. It's not a sustainable solution. But this very clearly is. Let folks that that are from rural Dakota and want to go back to rural Dakota to take up people they know, be able to afford to do so instead of forcing them into kinds of care that are more profitable. And also, a single payer is forced to consider, what do we pay on and how. If we pay per diagnosis, does that result in lower amount of time spent with patients? It does. If we pay for service, does that result in hospitals overcharging folks or overcharging others? It does. What is the model of care in which we take care of physicians and let them do the work that they want to do and take care of people long term? Now, the second part of that is that sometimes physicians aren't the best people to make these kinds of calls, right? I think of all malpractice cases in the US, 70% are from cognitive biases. Not technical fuck-ups, not like the person dropping a scalpel in your body, which happens and is scary, but most of the time when malpractice occurs, it's because a doctor looks at somebody and says, oh, that person's an alcoholic, that's what the problem is, their foot pain is probably not real, I'm gonna give them this thing. Or this person is an older black woman and I don't take her very seriously and I'm gonna ignore her or dismiss her pain. And that happens all the fucking time. I've spoken to those patients, you probably have too. But there is a model of how you solve that problem. That's you hire somebody to serve as a patient advocate. When a patient has an advocate, which is someone whose job it is to lay out for a patient all the kinds of care that are available to them, give them the full course of information, 2 things happen. 1, you get fewer doctor fuck-ups, and 2, the patient then has a wider array of care they can choose from. Right now, doctors will prefer surgeries, will prefer inpatient admissions over things like watchful waiting or let's wait and see or do non-invasive care, simply because that's kind of what they're conditioned to do by hospitals. There's a really famous study in New York where they took a bunch of kids with sore throats and brought them to a bunch of doctors, and half of those kids were recommended for tonsillectomies. They took the remaining kids, brought them to a bunch of doctors, and half were recommended for tonsillectomies. Brought the remaining kids were recommended for tonsillectomies. In general, a kid in New York has a 50% chance of being recommended for a tonsillectomy. In upstate Vermont, Vermont's interesting because basically every county is the same, so it's a relatively homogeneous population. Tonsillectomy admission rates vary by up to 7x in neighboring counties. The exact same people are put into hospitals for the same condition at very, very different rates, all based upon whether or not that hospital or that doctor likes performing tonsillectomies. But when you put someone else in the middle, when you have someone else say, hey, here are all their options, let's get you to get a more informed consent in the process, inpatient rates drop, malpractice rates drop, and you have somebody who goes to bat for you with or kind of against your doctor. Instead of kind of internalize the idea that patients should just download WebMD and be informed on their own, well, that's not reasonable because patients are under duress. If your kid is sick, you're going to do whatever the doctor says because your kid is sick. Same thing with social workers in primary care. Like if you are a person who's on the phone with customers all day, trying to find them the care that they're asking for, but your insurance provides, that's the same skill set required to help a person understand all the kinds of care available and help them make a more informed choice. We're also forced to invest more in evidence-based research to understand what kinds of care do and don't work. And until that happens, your doctor's at odds with other doctors who they probably don't communicate, there's nobody right in the middle, and your insurance stumps in every now and again to kind of kick things around based on what they do and don't pay. A single payer doesn't solve your specific problem immediately, but it's the only thing that ever could be used, I think, to solve that disconnect. Does that answer your question? Cool. You got anything?
We have time for one more quick question. Did anybody have any questions for Jen or Health Brigade by chance?
But I already asked you a question.
Me? All right, great. Tim, thank you for coming and visiting us. Seriously, the next time that you're not on the clock and hauling your ass all over the Southland, we have a lot of really good luchador and independent wrestlers. Come back, we'll serve you some beer. But my question is for Jen.
Good.
Sorry.
No, it's fine. While we absolutely want to put the shoulder behind the assembly issues,
Yeah.
we're probably stuck until we finish yanking the state out from underneath the GOP. In the meantime, are there other critical issues for Health Brigade that we can work towards? I mean, you only mentioned that one particular bill.
Yeah, I mean, I didn't prepare everything that we do.
No, off the top of your head,
Yeah.
what's going on with Health Brigade that we can work with?
I would say, we do so much. So generally, we're not an organization that does a lot of legal advocacy. We're trying to switch that and try to do more community-based and getting people involved. Generally, our history, well, it's funny because Fent-Free Clinic first started as first responders to protesters and things like that. So our background comes from community movements and organizing. And then as we moved on as an organization, we became more and more focused on physical health. And so what we're trying to do now more is shift it more into this organization that is more holistic, and also think, since we do so much work in the community with folks outside of our clinic, we're trying to sort of motivate folks that support us to also do the work, because like Tim is saying, there's just so much that we can do as providers daily. So I would say be on the lookout for information that helps, because we have planning teams and committees to push information out to support us. One of the things I can think on the top of my head is something that's really important to us is the needle exchange program. We have a chance to make that a reality right now. And from our conversations that we're having right now, a lot of it's basically stuck with law enforcement. We need support, and we need to hear from other folks that needle exchange program would benefit us. So I would definitely be on the lookout for how you can do that.
Quick follow-up.
Yeah.
We have, for the first time in a long time, somebody that may be a real advocate as the city sheriff.
Right.
Do do you think that there might be something we could do to help with a partnership with Health Brigade and the Sheriff's Department? Now
Yeah,
that
I
we have
think-
somebody that might actually care about those issues?
Right. I think the more and more that we can get it from our community, that this is not just doctors and nurses and folks that we're seeing dying and contracting HIV and Hep C and things like that. The more that we can get our community involved in saying this is safe for all of us together, that would be helpful for us, certainly. So yeah. But like I said, we're in the process of trying to figure out how to push our messages and our core things that we're going after to the community. So I would say stay tuned.
Okay. All right, done. Thank you.
Yeah.
That's cool.
And thank you, Tim.
Oh, thank you.
So yeah, we're just gonna have a brief intermission here before we have a screening of the movie Fix It, Healthcare at the Tipping Point. So grab another drink, smoke a cigarette, use the bathroom, do whatever you gotta do.